So as Deborah said, I'm at Vanderbilt University. I'm a professor of neurology. I've been at Vanderbilt for a little bit over 10 years. And I, shortly before moving to Vanderbilt, my second son was diagnosed as possibly being on the autism spectrum. My first son had been diagnosed when we lived at the University of Michigan. And I was a sleep specialist, actually an adult sleep specialist who saw an occasional child, but didn't really do anything with autism or neurodevelopmental disorders. I really focused on adult sleep, but that really changed everything when my kids were born. And I look at it as a blessing for them. I look at it as a blessing for me that I became involved in this area and in this field. And it's a very exciting time in autism and autism research, you know, with the increased prevalence, with a lot of new ideas, a lot of new thoughts, and a lot of new treatments and interventions. And one of the things that you'll hear me talk about today is how when we're sleeping better, and when a child is sleeping better, and when a family is sleeping better because the child is sleeping better, it can make a huge difference. So it goes even beyond sleep interventions to say, well, if you're sleeping better, if you are, as a parent, you can be a bigger advocate for your child. Your child can be more engaged and involved in therapies. So it really is, to me, sleep is a pivotal part of the intervention for autism. And we'll also talk about how sleep might actually be a marker of certain types of autism or help us understand autism better. So I hope to cover kind of a broad group of things today. The questions we'll address today include what sleep concerns have been identified in children with autism spectrum disorders, which I'll refer to as ASD. What are the causes, ranging from, on one end, the neurobiological, on the other end, the behavioral, and that doesn't necessarily mean bad behavior. It means things we do that can impact on sleep. And then the medical is in there as well. And what is the impact of sleep disorders and their treatment on autism? How do we screen for sleep disorders? How can you partner with your healthcare provider? As Osman was saying, how do we work together as a team to make this work? And then what treatments exist for sleep disorders in autism? I'm going to focus on behavioral treatments, but I'll mention medical as well and how behavioral and medical can go together. And then hopefully we can have an interesting discussion on how we implement these and what's useful to parents, because we're still learning what that is. You might have seen in your handouts that we're coming out with a book this fall, hopefully this summer. By all means, if it isn't this summer, it'll be this fall. And the impetus behind writing this book is we wanted to fill the gap where a lot of parents have said to us, we don't know how we're going to get training in behavioral sleep education. The pediatrician's office is busy, not necessarily here in Vancouver, but in Nashville and the States. There's so much to do. There's so many things the pediatrician has to cover. Can we have a resource? So that's what that book came out of, and we're really interested in hearing from you all what might work in your situation, because we are still discovering and still trying to identify the best way to get the principles I'm going to talk about today out to parents across the North America in a way that works for them and is practical. So just to bring everyone up to date, many of you in this room are already familiar with autism, but there have been some changes recently. The core symptoms are impaired social interaction, impaired communication, and restricted interests and repetitive behaviors. And with the moving from the DSM-4 to the DSM-5, which is a classification of different diagnoses used in psychiatry, the impaired social interaction and impaired communication have been put together. So now there's two bullet points rather than 3. One is the impaired social communication, how a child interacts with the world, and then this restricted interest, repetitive behaviors category. And this really is a spectrum. It can be the child in their own little world, as you can see here, that they are socially withdrawn, they're really keeping to themselves. But it can also be a highly outgoing, gregarious child who's socially awkward and just doesn't know how to interact normally with the world. And I keep using child. It is important to realize, as Deborah was saying, she now has a grown child and a grown child who's now an adult. And I have one is about to be a teenager in a month. My children are 12 and 15. So if I say child, you can try to remember that I really mean young adult as well, teen as well. And this can, over time, we oftentimes see improvement and individuals on the spectrum compensating, but these core deficits really do remain and tend to be lifelong. And the other thing that can go with the spectrum is it can be a spectrum in language. Some individuals can be nonverbal, others are highly verbal. IQ, there can be intellectual disability, others can be normal or actually superior intelligence. And there are many medical comorbidities or coexisting conditions, including epilepsy, which is seizures, and I'll show you some examples of that later this morning. GI disturbance, gastrointestinal disturbances such as reflux, constipation, anxiety and other psychiatric conditions, OCDs, obsessive compulsive disorder, ADHD, attention deficit hyperactivity disorder, and then sleep disturbance is very common. About 50 to 80% of individuals with an autism spectrum disorder have difficulty with sleep. And it's really interesting because we don't quite know why there's such a high prevalence of sleep disturbance as well as some of these other comorbidities. And one of the theories is that there's over stimulation of the brain and over connectivity. Another theory is there's a hyperarousal disorder where being over-aroused, overstimulated is driving these behaviors so that you have insomnia because you can't shut your brain down, you have anxiety, you may have GI disturbances. So there's different theories that are being tested and monitored. But these are all very common. And the interesting thing is, from a clinician standpoint, is the sleep disturbance intrinsic to autism or secondary to some of these comorbidities? Because we know that seizures, GI disturbances, anxiety, OCD, ADHD can all in and of themselves disrupt sleep. But then the flip side is really interesting too, right? Because could we affect these comorbidities and coexisting conditions as well as some of these core symptoms by improving sleep? So to give you some examples, if a child is sleeping better, we oftentimes see that seizure control is better. They don't have as many seizures. We find that the number of medications they need to control their seizures may be less if they're sleeping better. And then the daytime sleepiness that they're having from being on all of these strong epilepsy medicines is not hitting them as hard if we treat a coexisting sleep disorder. And a good example of that is sleep apnea. If you have sleep apnea and you're waking up multiple times a night to breathe and to catch your breath, and then on top of that, you're taking strong medicine for epilepsy, you're going to be very sleepy during the day. So focusing on sleep can really help, particularly in individuals who have some of these medical coexisting conditions like epilepsy. Another interesting one is anxiety. Anxiety can make it harder to go to sleep at night. You're anxious, you're scared. But then if you sleep better and different strategies can be put in place to help you sleep better, then your anxiety may actually dissipate. You may be less anxious during the day. You may be able to, it's kind of like a positive circle, not a vicious circle, but a positive circle where you break an association and then you find that everything improves. So we'll talk more about those issues today. And then the core symptoms, it's interesting, particularly this ability to interact in therapy and learn in therapy how to interact better with the world. Like in behavioral therapy, if a child comes to the therapist grouchy and grumpy and aggressive and irritable, you're not going to be able to get as much done if they're sleeping better. So the idea of using sleep as a means to improve the child's ability to work in a therapy session is very exciting to me, as well as the parent's ability to be an advocate for their child, because the parent is actually sleeping better too. And how many people in this room are parents, even if you're other things? I mean, do we have a lot of parents? Okay, so we all know, I used to think it was really interesting when I would be really tired, I would be really grumpy, I had been sleep deprived, and my kids would be acting up, especially when they were little. They still act up, but when they were really little. And I was thinking, darn, the timing is so bad here. I'm tired, and they're tired, and I'm tired and they're acting up. And then one day I made the connection between the fact that, when I was grumpy and irritable, because I was tired, it was making them grumpy and irritable. And when I modeled, when I slept better and I modeled better sleep and being more alert during the day, they were less irritable. And that's when I realized everything is really connected. So some of the benefits on the child, I've come to think, are not only because the child is sleeping better, but because if the child's sleeping better, the parents are sleeping better because they're not getting woken up, and then they're able to interact with their children in a more, a more effective way. So lots of benefits here, I think, to treating sleep and thinking about sleep that go beyond sleep and get into both the child behavior during the day and the parents as well. So with that said, sleep is one of the most common concerns that parents of children with autism will bring to their medical provider. I said about 50 to 80% of the time. And what's really neat is the sleep community, whether it be the American Society for Sleep Medicine or American Academy for Sleep Medicine or the National Sleep Foundation in the US, and I know you have similar groups here, has really identified autism as a priority population for targeting interventions for sleep disorders for the reasons I mentioned, the child health, daytime functioning, the family, and they're very treatable, as I hope to show you today, that sleep disorders, whether there's a medical cause or a behavioral cause, are very treatable. But how do we do it? How do we screen for sleep problems? How do we evaluate for sleep problems? And how do we treat problems in children with autism is really not there yet. And that's kind of where we need to go. So this is just a slide showing the prevalence, about 50 to 80%. For the most part, objective measures have borne out parent concerns, and we'll talk about later this morning what is a sleep study, what is polysomnography, what is actigraphy. If you look at the percentages, it's higher than in typically developing. TD is typically developing children, so kids with autism have more sleep problems than typically developing. And it's all across the spectrum. So we now call it autism spectrum disorder, but you've probably heard about the Asperger and the PDD-NOS, pervasive developmental disorder not otherwise specified, autistic disorder. So regardless of spectrum diagnosis, sleep disorders are highly prevalent. Regardless of cognitive level, sleep disorders are highly prevalent. And this has been shown in multiple studies. In our, so what is the Autism Speaks Autism Treatment Network? You'll hear about it today. If you pick up the brochures, you'll see the ATN and then the AARP. I just wanted to mention what it is. Autism Speaks is a large parent advocacy group. that funds quite a bit of research, particularly in US and in North America. One of the programs of Autism Speaks is the ATN, or the Autism Treatment Network, and it was developed to focus on medical issues facing children with autism, and now we're starting to look at adolescents and young adults as well, because the emphasis has been on genetics, the emphasis has been on some of the more obscure causes, and they wanted to be very practical and really focus on these medical concerns. And the reason that I've been so involved in the Autism Treatment Network is because sleep, as I mentioned, is one of the major medical concerns that parents voice as a concern. So they have funded a site at Vanderbilt on which I serve as the principal investigator. I also am co-chair of the Autism Treatment Network subcommittee, which is 17 sites across the country, and we bring the sleep specialists together on the phone once a month, and we develop projects and toolkits. We developed a practice pathway, which I'm about to show you, for how to evaluate and treat and monitor kids with autism who have sleep problems, and we've also developed these booklets and toolkits and quick tips. This is the one that just came out last month. We're really excited about it. It's for teenagers with autism. So I'm really excited. They're available free of charge on the Autism Speaks website, and you should have some hard copies that you can pick up today. And one of the things we did early on is we took our registry, because one of the things that Autism Treatment Network is doing is enrolling kids in a registry, a research registry, so that we can look at patterns, we can look at medical issues, we can track what's happening over time. And we had more than 4,000 kids enrolled in the registry in March of 2012. We had, of those, more than 3,500 parents who completed the CSHQ, the Children's Sleep Habits Questionnaire, which is one of the questionnaires in your booklet. And then these are the domains on the CSHQ: bedtime resistance, sleep onset delay, night wakings, sleep duration, sleep anxiety, as well as parasomnias, which we'll talk about later this morning, are unusual movements or behaviors in sleep, sleep disordered breathing, and daytime sleepiness. We found that 2438 parents endorsed sleep problems on this questionnaire, so there's 68%, and which matched up with what had been described in the literature in smaller samples. This was a really large sample. And we found a mean on the Children's Sleep Habits Questionnaire of 47, which was much higher than what was seen in typically developing children without sleep problems, which was 41. And then we found no differences based on gender, age, diagnosis. Again, this was the PDD-NOS versus Asperger's versus autistic disorder, or IQ. So across the spectrum, sleep problems were prevalent. And of sleep problems, the most prevalent concern is insomnia. And insomnia has been defined as repeated difficulty initiating sleep, the duration of sleep, the consolidation or how solid your sleep is, the quality of sleep that occurs despite having age-appropriate time and opportunity for sleep. So this isn't the teenager who doesn't have enough time to sleep because he's working too hard on his homework and then he's going out with his friends and then he's, getting up early for school. This is actually having difficulty falling asleep despite having enough time, or night wakings, or some of these other things that are listed here. And then there's also got to be some daytime functional impairment for the child and or the family. So these are how sleep insomnia can manifest: difficulty, prolonged time to fall asleep, preference for a delayed bedtime in the older children, bedtime resistance in the younger children, sleep anxiety, decreased sleep duration, increased arousals and awakenings, or waking up really early in early morning wake time. And the causes are really quite almost a spectrum themselves, quite different and diverse. At one end, we have the biological, the neurotransmitter abnormalities, melatonin, you'll probably have heard of. We'll talk more about melatonin later this morning. GABA, serotonin. These are brain chemicals that have been shown to be altered in autism that also affect sleep. Medical, I've already alluded to GI problems and seizures, which can contribute to waking and insomnia, as well as some of the psychiatric conditions. And then the medicines that we use to treat depression, to treat anxiety, to treat ADHD, to treat seizures can oftentimes contribute to insomnia. Sometimes they also contribute to daytime sleepiness, like the anti-epileptic drugs. Just because a child has autism does not mean they're immune from having other sleep disorders like sleep apnea, the parasomnias, which are the abnormal movements or behaviors in sleep, restless leg syndrome, which is one of Osmond's big interests. We'll talk a little bit about that later this morning. What's interesting about restless legs is there's a nutritional link where if you have low iron from either a restricted diet or being on a certain type of diet, you can have that develop. And then the behavioral category, which was really near and dear to my heart. Again, it's not bad behavior. It's actually linked to autism itself. In other words, we know that children with autism have difficulty with emotional regulation, transitioning, going from one activity to another. If their routine is disrupted, it can be very hard. They might have a meltdown. Also, understanding parental expectations regarding sleep. It's a communication disorder. It's a social communication disorder. So kids with autism don't always know what the expectations are. And their parents, many of you guys, have so much on your mind and there's so much going on that thinking about implementing a bedtime routine, I mean, you're exhausted. You're just trying to do what you can for your child and be your best advocate for your child. And it can be very overwhelming, particularly when you read a book on, well, if you just let your child cry and don't go right back in, they'll soothe themselves to sleep. It can be very overwhelming. And so really focusing on this category and figuring out what is specific to the child and realizing that the child with autism does not necessarily fit the mold of a typically developing child, where maybe leaving the room and letting them sort of work it through and fuss a little is going to work, is not necessarily going to work for the child with autism is very, very important. So coming up with new strategies, coming up with things that work for the family. And this is where I probably need to just take a step back and say, I've been doing this for years and families really oftentimes respond to me, but I was in clinic a few weeks ago and it was very humbling because I did all of this with a parent. I had extra time. I took my time. I made her a bedtime routine. I pulled out the Velcro. We figured out what worked for her and her family. And she looked at me and she just started crying. And I said, what did I do? And she said, well, I really appreciate everything you're doing, Dr. Mallow. Your efforts are really appreciated. I know you're trying, but I can't make this work. I'm divorced. My child is with my ex-husband a lot of nights. I don't know what goes on there. I'm trying to make ends meet. I'm trying to work this job. The ability to sit down and really put a bedtime routine together and put all these things in place, it's just not going to happen right now. And can you please give me a pill, And it was very humbling because I realized that, and she was telling me I had the best of intentions, which was nice, but I was really feeling like, here I am I immediately called my colleague who's working on this book with me, Terry Katz at University of Colorado, and I said, Terry, we have to have a chapter called How to Work in the Real World, and we actually did modify some of our cases to be more real world, but it made me realize, and I really want to say it, before it goes too long today and we get too much into the material, you do what you can, and it's not unusual for me to meet a family for the first time in clinic, rule out the medical things, make sure I've ruled out sleep apnea, order a sleep study if I need to, do all of that, and then come up with like one thing for them to work on. And it might be child comes home from school at 3 p.m., don't let them go into their PJs right away. Keep them in their street clothes until you start the bedtime routine, then put them in their PJs so then they start, realizing it's bedtime. I mean, it may be one thing that the family can work on, and then when they come back in a month or two, you can introduce something else. And that is something I really want to impart is the last thing I want to do today is overwhelm you with any of this, because a lot of times it really is a matter of meeting the family where they are. And, sometimes it's a new diagnosis, and there's so many different things to do. And sleep falls by the wayside, even though sleep could be the trigger for meltdowns, aggressive behavior, impulsive behavior. But sometimes we have to really work with families and say, this is all they can do, and this is all we're going to be able to do for now.